Welcome to Health System CIO's interview with Dr. Priscilla Frase, CMIO and hospitalist at Ozarks Healthcare. I'm Anthony Guerra, founder and editor-in-chief. Dr. Frase, thanks for joining me.
Thank you, Anthony. I'm happy to be here today. I appreciate it.
Oh, you got it. Why don't you start out by telling me a little bit about your organization and your role?
So, Ozarks Healthcare is an independent rural health care organization in South Central Missouri. We have a 114 bed hospital. We also have 28 clinics, including 8 rural health clinics. We have a large inpatient and outpatient behavioral health component to our organization, as well as oncology and home health and hospice services.
All right, very good. So I reached out because you received the Chime Innovator of the Year award and the HIMSS Senior Executive Changemaker award. So you've done quite well in your sweeping award season. So well done, and that's why I wanted to reach out. Obviously, you're doing some interesting stuff. People are recognizing it. So I guess a good sort of first off question is. Um, what is your feeling if it wasn't expressly stated, it probably was in some of these things, and we'll touch on it, but in your opinion, what do you think are sort of the most special things, or the most impactful things that you've been working on that may have contributed to these recognitions?
I've been very honored and blessed this year to be recognized for the work that I've done. Sometimes it's hard for me to realize that the work is necessarily that special, but in smaller organizations, there is not always the resources to be able to get some innovative and insightful things done. And I think a lot of the recognition really evolves around my passion for continued optimization and excellence with the EMR. Everything really started with participation in the class Arch Collaborative, which aligns very well with my own desires and wishes and wants with the EMR for personal use, as well as for those providers at my organization. Being
Mhm,
able to get data to say how we're doing around EMR satisfaction for end users, both physicians, mid-levels as well as nursing staff, and then being able to act on that data and find ways to improve and then remeasure and show that we have continued to enhance things. The journey started when we had multiple different EMRs and we went to a consolidated EMR with Meditech Expanse, and we showed significant improvement across the board and satisfaction with that, not only in ambulatory and in acute areas, but also within behavioral health environment around utilization of the EMR. And from there, taking feedback from the Arch Collaborative and finding ways to be able to add on technology to enhance the end user satisfaction with it has really been a lot of it. And some of it has also been around getting very creative with vendors to be able to find resources to be able to afford add-ons and doing lots of things that didn't necessarily cost money, just hard work, time, and collaboration among colleagues, both here and with vendors.
okay, let's, a couple areas to follow up there. I'm really interested in the idea of getting creative with vendors.
Yeah.
Tell is that, just better negotiating skills, or what does that mean?
I've always been willing to help vendors if they work with me and we're able to find data that shows that the product was good for our organization and enhanced workflows. I don't mind participating in webinars for that
Mm,
vendor. I don't mind participating in white papers. I don't mind speaking at conferences. I don't mind speaking to other organizations about what's worked well for us, as well as what's not worked well and what could be better. I
mhm,
also don't mind working with those vendors to help improve their product for all end users.
mhm,
And so having that willingness to provide some of that feedback to the
mhm,
various vendors over time has given me a reputation of being somebody that's good to work with, which has
good.
helped me have a little bit more negotiating power with that. I don't mind being an early adopter for a lot of add-ons that we can get for the EMR. And so can get that early adopter pricing and then continue to help support the vendor's efforts to grow that product down the road.
So that is, how would you articulate that approach for some of your colleagues, maybe at smaller organizations, rural organizations? How would you articulate the approach Is it like sort of a two-way street, meaning we're going to help each other, a real partnership? How would you tell them? I mean, and I guess the opposite of that is maybe more transactional, and you just give me what I paid for and go away. I mean, help me articulate this better.
Yeah, no, I think it is more that two-way street type of thing. And where a lot of this started, actually did have a lot to do with my participation with the Class Arts Collaborative. Participation in Class Arts Collaborative is not super expensive, but anything you add on to a budget in a small rural health organization is a line item that is ready to be cut at any time to save money on something else. And at one point in time, I was actually willing to use my own credit card to pay for us to stay within Class Arts Collaborative. And I think when that ended up leading to us being able to get a price that we could afford and negotiate what we needed to do to stay within participation in the Arts Collaborative, it kind of made me realize that when that passion is there to be able to do what's best, not only for your organization, but also for the vendor on the other side and have that two-way street, that you can utilize that. And sometimes it's hard for organizations to find that position that's willing to push it forward. And I think being a physician that was in that role rather than just the IT team has helped me push that along with different vendors over time. I know the clinical workflows on the physician side. I know some of the workflows on the nursing side. I'm not just an IT person. I still practice and can provide that practical feedback to it. So it's definitely a two-way street with that. This is what I'll give you. Give me what I can, what you can give me in a discount. I might be able to get this through on a budget. Limit things to one-year contracts. Try to have continued incentives for contract renewals after that, even after that time frame, that you can definitely get the improved pricing as an early adopter, and just whatever it will take with that. And I also follow through with my commitments to help with talking to other sites, presentations, and things of that nature. I think one of the things I hear from some vendors is that sites will say that they'll do that, but then they don't
Mm,
follow through helping out on the back end. And
mhm.
by repeatedly abiding by that agreement on my side, vendors have learned that I'm going to continue to help with that.
That's very interesting, and I think you're touching on something interesting here. And I've always thought this as well. Being a pleasant customer will get you better service. Just be
Hmm.
a pleasant customer. Be someone that's pleasant to interact with. Be appreciative of good service and express that appreciation. Say thank you
Yep.
because we're all human beings and everyone likes to be treated well. And it just, I mean, what's the expression? You get more flies with, it's a horrible expression with flies, but you get more flies with honey. It's a very unpleasant visual, but you get more flies with honey than with vinegar. I think that's it, right? Honey
Yep.
and vinegar. So
Yep.
we wanna be around people that make us feel good. If you as a customer have that in the back of your mind, do what you say you're gonna do. Think of it as a two-way street, and they have needs too. And you're not saying anything that's not true. So you're not saying something that's working poorly is working great. You're just saying, "If it works well, I'm be willing to tell people it works well." So
Yep.
it's just a smart way of doing business.
Yeah, and I mean, I've even have I'm honest with people about the vendors about things that don't work well. I have no problem sharing that feedback, and I've had them tell me, "You give negative feedback better than anybody. We can receive it because you're so pleasant doing it." You know, nothing around IT technology is perfect for everyone. Somebody's going to complain, whether it's the providers, the nurses, the registration staff, revenue cycle people, or the infrastructure sysadmin people. Somebody's going to complain about everything,
Mhm.
but you can still point out what's not working in constructive ways and try to help them understand your side of the world so that they can make it better for others down the road. And you have to be willing to take some of that more challenging workflows and technical issues at the beginning stages to work out the kinks, so to speak. But there's benefits to that.
Yeah, so also interesting that that idea of negative feedback. When you feel that you're not being given appropriate service or appropriate responsiveness, that your requests or complaints or however you want to put it are not being addressed in an appropriate manner, I'm assuming you have no problem letting people know that and perhaps escalating if necessary. Like you'll do what you got to do.
Yeah, I've learned that over time. I haven't always been as articulate as I might have needed to be in that. The business side of medicine has never really been the thing that I learned. I've picked it up as I've gone along. And so I've had some times that I wasn't as articulate as I needed to, and contracts have ended because I didn't get what I needed. But I'm learning to be more vocal about what our needs are and being practical with
Mhm,
it and
mhm.
realizing that if that information's not out there about what is and isn't working on both sides of it, then we can't come to some kind of cooperative agreement to move things forward. And so I'm okay sharing what I need from people. And sometimes I ask for more than I need just to see what I can get. And I've learned to play that game a little bit.
That's right, start high in the
Yeah.
negotiations. You're supposed to start high. I've never been good at that either. There's some
Yeah.
people that are great at that. They're just naturally good at that kind of thing. Let's talk a little bit about the EMR and the EHR, whatever you wanna call it. The idea of physician dissatisfaction, frustration, the things you hear that, listen, we know these things, or most of these things were initially built for billing, around billing, and not around clinician workflows, and doctors banging their head against these things and contributing to burnout and a point of frustration. Um, we're obviously consolidating from many to one can be helpful, because then it's just one thing I have to learn as opposed to three or four different types of things. We hope, or we hear, that ambient listening and certain AI technologies may make these EMRs a little more pleasant to interact with. How would you articulate, as a clinician, the biggest frustration points with EMRs?
The frustration points are different for different providers. For me, personally, it's the amount of data to go through to feel like that I've gotten everything that I need to know about the patient, and every year more of that information is out there for me to see.
Mhm,
Um, when you get data from outside sources, it just adds to it. And do I really know everything I need to know about the patient? A lot of it is I mean, I hate to harp on it, but it's the clicks and the different screens that you have to look at and moving from one place to the other and not being able to see everything in one view where you can just kind of look at it, see it all, take it in without having to move around to things within the EMR. And the things that we have to do that seem to be more administrative. I grew up in a paper world and there were other people doing a lot of these things, but when you get to automating them, um, you suddenly become the person that's having to do that, and finding ways to take that away from the providers that are using the EMR and automate that in the background, whether that be with AI tools, whether it be just building in rules to have things happen automatically, whatever you can do to minimize what we as physicians have to do, to where we can focus on documenting what we need to document, to remember what we need to take care of our patients, have those bills drop in the background without us having to do a whole lot with it. I'm really excited about things in the future with AI potential. As things work out with it, we have several platforms that we are in trials with right now to see what all we can find in terms of efficiencies with it. But the EMR was not built for what we do. It was
mhm.
built for all that back end stuff, and trying to now push it to where the EMR lets us be who we want to be using some of the ambient listening tools and other AI and automation opportunities that are out there. I think it's the first time I felt like we could get it back to what it used to be on paper. Not that I want to go back to paper where I don't have access to all that data, but make it where it doesn't feel so intrusive into the workflows.
Yeah, really, really well said, and very interesting. Let's talk about a couple points there. One is that crazy sort of trick you mentioned, which is I didn't have to do certain things as a physician on paper. And as we transition into electronic world, all of a sudden they became my problem and my responsibility. How did that happen? It's crazy.
So I have a theory about that, and it just when I was very against DHRs when I first started using them, working at the VA the minute it went from paper to electronic, and this invention of this problem list that immediately within 1 week had errors on it that you couldn't seem to get out of the darn EMR, and they were there forever associated with that patient. I mean, that's from my first month of using EMRs. I saw that, and the EMRs are totally based on a problem-oriented medical record, and that problem list that was developed on paper back in the 1970s, the way it got extrapolated into EMRs just wasn't as seamless. The problem list in the paper chart, you looked at it, you hand wrote what you wanted on it, you went on with it. It wasn't this ingrained part that everything had to be accurate and addressed outside of your normal workflows to be able to have everything function the way it was intended to be.
Mhm.
And I know for me at our organization, when I've been able to get people to understand that the problem list is a lot of the foundation of how things work and can be more efficient in the problem-oriented electronic records that we have today, it's at least more palatable than it
Mm.
is when you think that everything's fighting, because some of it makes more sense. But I think it was that taking what seemed to work well on paper, that one pivot point of that problem list, and then expanding from there to make everything meet, I think
Mm.
is kind of what muddied the waters rather than taking the ordering and the documenting parts of it and coming out from there. If we'd started that way and let that problem list evolve naturally like it did on paper, I think it would have been a different approach with it all.
Very good, very good. All right, the other point I wanted to follow up on, when you referenced the idea of seeing things in the way you want to see them, right? Regarding a patient, you have a screen in front of you, and depending on what's going on with the patient, you would like to be able to see on that screen, however big it is, the information that you need as a clinician to process and amalgamate and let it swirl around in your head and come up with the idea. And the problem, and I'm sort of just repeating what I think you're saying, is when it's not there. So
Yeah.
something there, but in order to do what I need to do, the rest of the information isn't there. I've got to go perhaps into other systems, log in somewhere else, at the very least go to other screens. And therefore, I almost, in order to get the visual cognitive view I want, almost need to maybe write it down so it's all on a piece of paper, the data I want, so my brain can do what it needs to do.
Yep.
And Mr. IT person or Mrs. IT person, you're not letting me do that. You're making this so hard to do a hard job. Is that kind of it?
Yeah, no, I think that that is a lot of it, and a lot of the push around personalizing EMRs for what individuals want to be able to see to kind of minimize that is where a lot of that comes from. And you have to teach providers how to do that, not only um, for them, like, to be able to do that for themselves, where it's not just IT doing it, because sometimes things change by the patient, and it's hard to get there, even with the personalization capabilities within different EMRs now. There's still always something that somebody wants that's not available or can't quite do the way you
Mhm.
need to. And yeah, they do write it down on paper. I really try to make a point to not use paper when I can, but every now and then the easiest way for me to see it is to put it in front of me where I can have it the way that I'm accustomed to visualizing that. I think for those of us that came from paper, that's it's a little bit different experience than those that have only ever trained in the EMR. They're kind
Mhm.
of used to that. And so I think where we're at now is sort of transitioning to meet those needs of the future rather than just helping those of us that came from paper and have seen this world evolve to where it is now.
Right, and this is why the CMIO role is so important, that transitional role between clinical practice and IT, because as you said, you want to make things somewhat customizable. Clinicians have different preferences of information they want to see, ways they want to see it, the color they want to see it in, the color they want the background, right? So we all would love to be able to like have a palette or like a whiteboard kind of thing, and this is exactly how I want to see it for this patient based on my training and my. We know that's almost impossible to do, but we want to provide some customization. As a clinician, you're in a position to be able to evaluate a request and to say, that makes sense, or to say, you're just being crazy. Not that you would say that, but you might say,
Oh,
this
I
is such
might.
a this this is such a one-off that I'm never building anything around this request because it's so weird. And as a clinician, I
Yeah.
know it's weird, right? I mean, you must get all kinds of requests.
Yeah. No, I get that. I get that all the time. I work with the providers at our organization, sometimes meet with them one-on-one, have regular meetings in groups and hear every complaint that they have. Also get written complaints when we do repeat surveys on things. And, some things are I get very insightful information from users that don't practice the same way that I do, even other hospitalists that do the same work. They provide information that helps me make things better for other people. So I pay attention to the workflows that everybody has and all of those nitpicky little things, because it's quite remarkable how often you can actually fix one thing just by knowing what the problem is they don't like. And we
Mhm.
recently had a new oncologist start. He tells me the one thing he doesn't like about the EMR. I go and talk to the IT people. We get him set up with something different for his workflow. Voila, we fixed it. If he hadn't mentioned that one thing that he didn't like, we wouldn't have been able to get what he needed. I've got to follow I back up with him and make sure it truly met his goal. But
Mhm.
you got to hear those complaints and figure what some are. And even those things that I think might be way out there, if I listen meaningfully to what the person is saying and watch their workflow and understand it, sometimes I realize they're right. Sometimes I realize I just have to help them find a little
Mm.
bit of a tweak in their workflow to
Mhm.
make it work with the system that we have. But if you
Mhm.
don't pay attention, listen, and experience from their side of it, as well as those downstream things that you might mess up if you change stuff too much, you can't find that middle ground that works better than the alternative of them being mad.
That's great advice. Just a couple more points I want to touch on, then I'll let you go.
Okay.
You mentioned you sort of touched on it, I think, in your last comment, the idea of governance. We hear from what everything I hear, governance. It's super important. Having
Mhm.
those bodies, committees, things like that, sort of a formal structure around gathering requests, complaints, all these kind of things, so that you move forward in a direction that makes sense. What are your thoughts around governance?
Governance is very important. In an organization like ours, a lot of times providers want to defer the governance to me, but I'm not the governance. The governance needs to be a group effort, and I think that's probably my biggest challenge here. Is yes, I have the knowledge that they need, but I have to take that knowledge and share it with them so that we can make a group decision that's going to be best for all fronts. And sometimes what the physicians want isn't going to meet the governance needs of what the nurses want, isn't going to meet the needs of what the organization wants from financial side of it all, or a regulatory side of it all. So that governance is super important, and having an engaged governance where people feel like they can talk to you about things is also pivotal. With that, one of the things that we scored highest on with physicians is they felt like they had a voice with IT, that they could talk to us. And I think that's probably one of the most things I'm most proud of, that we're approachable as an IT department. With the physicians, a lot of that is me, but it's also other people within the IT department. They know they can voice it. They know when I can fix it, I will fix it. When I can't fix it, I'll try to find an alternative for them. But you've got to have those processes in place, those policies in place. And when things get crazy, you refer back to those policies around your governance. And usually by following those kind of guiding principles, you can find a way to move forward through whatever it is, the challenge that's before you.
Right. Excellent. Excellent. You mentioned going back to the IT people in your organization to see perhaps if they can make a tweak or make an adjustment. Would that be sort of level 1, and then level 2, if they can't do it, would be going back to the vendor,
Yeah.
and trying to get the change made? And a lot of with these vendors, they have hundreds of customers. You're one customer out of 100. They have their roadmaps, they have user group meetings, but you wanna get your voice heard, maybe get on the roadmap, or at least find out if other people are making the same request. How would you describe working with the vendor and getting them to embrace, or at least listen to the changes that your users are requesting that you can't make in your shop?
It's been a partnership that has developed over many years. I'm somebody who has used Meditech since my early days using an EMR. I didn't get directly involved with them until I took the position at the role that I'm in now. And at first, when I would complain about something, I think that's probably the key word. You got to rephrase things where you're not complaining, you're not offering suggestions, you're participating, you're trying to help make things better for
Mm.
everybody. And it took me a long time to come up with a way that the vendors heard what I said. And a lot of it was being consistent
Mhm.
in the messages that I brought across, having data to back up some of those messages that I had. So it wasn't just me saying something, following through when I said I would follow through with something, and then participating when they offered for me to be on this committee or on that committee or to help with this group or be a part of this user experience group and things of that nature. So you have to be invested with the vendor as well. And over time, those relationships become pretty special. And I'm not, nobody is ever going to be something, hey, you asked for it, you're definitely going to get it. But at least people are going to listen, they'll
Mhm.
consider it. And I'm okay if they say no, but I have that voice now. And that voice has been really remarkable to get coming from a small organization in a rural area to be able to have that. And I'm super grateful because a lot of us are in the same boat. And the more I can share about what we experience in rural health areas, I think the better for all of us in rural areas.
That's great. Just as a final question before I let you go, what's your best piece of advice to, and let's, I always try and articulate this in terms of someone at a comparable organization. So same type, rural, same size, just somewhere else in the country. You're speaking to the CMIO there. What's your best piece of advice?
You know, my best piece of advice is my three P's. I stole that from somebody, but I converted it into patience, meaning the patients themselves, as well as being patient with everything. Persistence, and for me, it's always been that passion. You gotta stay positive with it as well, so that maybe that's 4 Ps, but just carrying that through and being true to yourself and what the end goal is, which is to make it better for everybody. And when I say everybody, that's not just the patients, it's not just the doctors, it's not just the nurses. Try to make it better for all of them and make it better for the organization also.
Dr. Phrase, that was incredible. Really wonderful conversation. I want to
Mhm.
thank you so much for your time today. I really appreciate it.
I appreciate you, Anthony. Thank you for having me on.